Because as it is right now, participatory forums are held during the weekday working hours, in a way locking out every voice that is in formal employment. So I think one of the most outright things that Makueni could consider, I know perhaps the public officers there may feel like, you know what, that's my off day or something, but they should consider having participatory forums over the weekend. Number two, I think Makueni needs to invest more in a holistic approach of empowering citizens in public engagement. I know that through what they call the ward public participation officers, they train citizens on how to participate, but perhaps they need to go the step further and train them that, you know what, as you participate and propose for a physical infrastructural project, you might as well also consider programmatic financing of that project as you make your proposals. Lastly, my third recommendation would be, this is more on the political side of things. I feel that participatory budgeting is a nice framework and tool for project management. Perhaps what Makueni needs to do in its design is reconfigure it in such a way that they look at the citizen as a partner in governance, not as a client in partnership in development and governance. And perhaps through this way, as literature suggests, they can be able to promote better economic and social rights and have better prospects in poverty reduction. And with that, that's the end of my presentation.
So, any quick questions?
Thank you. My name is John Kinuthia from IPP. I think one of the things that we've heard and we've seen the governor of Makueni speak a lot on TV about is a very innovative approach to how Makueni has or is planning to move towards a universal coverage within their county. Now, is the participatory budgeting idea here part of that, what sounds like a broader approach that they are trying? Because from your presentation, it sounds like this is really focused on the development side of the budget. But is this part of a broader discussion that is happening about how to make the healthcare in Makueni more equitable and the approach more participatory?
Okay, any other?
I want to ask something very specific to what you said. Yes, people come and they talk about infrastructure and they get their success of participation based on how much brick and stone has been laid. But did you come across instances where people actually are specifically concerned about the fact that there is no staffing in these health facilities and therefore an issue also of advocacy? And how is that taken up?
All right.
Okay, so we'll let you take those two and then see if there's some more.
Maybe starting off with John. During my data collection, something interesting that I came to learn is that there is an underlying degree of conflict between the departments in Makueni. So you'll find that they sort of say on paper that they are working as one whole, but there is what was described actually by the Directorate of Public Participation in Makueni is that there isn't a harmonization that accommodates public participation holistically in the different ministries. Basically, public participation has been seen as a platform for collecting information, BAS. Yeah? So you find that, yes, the health docket may be working with the health, with the universal health policy in Makueni, but there's sort of this other thing that it also needs to do to, in a way, take care of citizens' proposals. Yeah? Because my belief is that in the grand scheme of things, PB, how is it's implemented in Makueni, first and foremost, legitimizes, the function, first and foremost, is to legitimize government policy. Yeah? So it may not necessarily be that there isn't that seamless harmony between some of outputs in public participation and the sectors. Abraham, kindly remind me, what was the question again?
So the link between the fact that health facilities have been built And there are instances where people actually raise issues about the human resource aspects of it. It's likely to assume that nobody raises about it. And are there any formal responses to that kind of challenge?
At the moment, I haven't been able to collect data that suggests that citizens have actually registered this. I'm trying to look into feedback mechanisms that exist in the PB process in Makueni. Unfortunately, there isn't such a clear feedback mechanism in the PB process in Makueni, but that's something I'm keen on finding out hopefully soon. Yeah.
But just related to Abraham's question, have you considered the possibility to adapt, to try and model this around participatory monitoring as well? So that there's the budget side, but also the monitoring to try and figure out the efficacy of some of these programs. And then a related question is, how much data could we put into the system so that there is some fair basis of evidence and real empowerment? So citizens actually direct their participation in a way that is guided by what's mostly needed. And I guess so that goes back to how much sub-county level, how much county level data is available with these processes. Because I think the fact that it's being implemented and it's something that seems to be working is an opportunity to build it and just strengthen it. And therefore see various ways around monitoring and evaluation, but also how do you sufficiently provide spaces for public education, but also data. As I said in the morning, how does this conversation inform those guys at the grassroots in terms of, do we need a cattle deep or a clinic? Or if we need a clinic, what should it focus on? Should it focus on, do we need something maternal? Do we need something pediatric? Or do we need something that is catering for the old, for instance, things along those lines?
Maybe I can start off with your second question. At this point, I don't know how well Makueni is investing in data, but I know IBP has done quite a bit about, should I say, data accessibility from the different counties. I know there's even sort of a table or index where you get to show maybe the county physical strategy paper from this county has been released. But as far as data through PB is concerned, I don't know how much of it is out there. Maybe that's something to also consider. And your other question about participatory monitoring, I'm happy to report there is actually a framework on how that can be conducted. Makueni has these committees, they call project management committees. Again, it's very project oriented. So after a proposal has been approved and financed, so you find that a contractor is given the bill of quantities. So this is how you're going to implement it. And that bill of quantity is also shared with citizens in a certain area or village. So it's about a group of 11 individuals. So they basically get to come and evaluate how many cement bags, how many did you use, how many were left over. And if you implement a project and they're not satisfied, you're not going to get the, because they have to write a report to the treasury, county treasury, and say, you know what, we're happy with the work this chap has done. Otherwise, you don't get to receive your payment in full. Yeah.
But I'm thinking about just questions from what he asked. How do we know that these, because the whole thing is towards specifically focus on health, is towards universal health coverage, but also the quality of the services.
Yes.
Like for instance, here's a dispensary, but the nurse doesn't show up. Here's a dispensary where the askari is the one who is doing IV. So things along those lines.
And actually that has been one of my curiosities during my research study, is that participatory monitoring ceases to exist after a project has been implemented, an infrastructural project has been implemented. There isn't any focus or investment in services and programs or engagement past physical infrastructure, unfortunately.
So maybe, not to put you on the spot, but is this something that they would be willing to think about? Because, you know, as we mentioned in the morning, this devolution really has to work. Yes. Otherwise, we are really cooked. So I'm interested in this because it seems like they're on a path to something. And now it's on people like ourselves here to say, well, here are some other directions you could go. And one of the things you talked about was administrative efficiency. It's not just timely execution of a project, but is the project serving its purpose? and the users getting value for public resources.
Right.
I think that's really where the path you want to walk it down.
Right.
Yeah, I just wanted to ask a question. Edwin, thanks for the presentation. I think this is a very important presentation because of the way that this process has been portrayed by the people who are heavily invested in how it looks. And it's good to raise questions about it and to give a more balanced perspective. But since we are in Equity Week, one question I wanted to ask is, how is equitable distribution taken into consideration in how this is done? So is it, or is it taken into consideration? So for example, are we able to say that there are particular wards or particular parts of the county that need these facilities more, or that need certain kinds of investments more, and therefore they're getting them through this process? Or is this what we've seen in other counties, which is that all of the wards are being treated equally, even though there are huge differences across the county and who needs access to what? So to what extent does this process, not just, you've talked about some inequalities in who participates, which I think is an important part of it, but also in terms of who gets what, to what extent is equity taken into consideration in the way it's designed?
That's a very interesting question. I'm compelled to think that there is infrastructural equity, in the sense that there is a dispensary which is accessible to pretty much every citizen within 5 kilometers of where they stay. But if you have to consider access to actual healthcare services, you find that mostly urban centers have a bias in favor of them. For example, in one of the facilities I visited, this individual was telling me, when we have emergencies here, I mean, when we have somebody with an emergency that we need to address immediately, we just get to do first aid and refer them to hotel. So basically, this tells you that, yeah, the facility is here, but access, there is still inequality to access to quality healthcare services. Because with this, most of these PB-initiated dispensaries only get to offer level 1 and level 2 healthcare services. So not much has changed. There's that urban bias in how healthcare services can be accessed.
So my question is, did you go further and find out if during this participatory budgeting, once the citizens give their ideas and opinions on what they want, does the county government come back and give them feedback in case where they did not consider the things that they wanted? Does the county government come back and tell them, we didn't build this dispensary here, or we will not going to build this dispensary here because of X, Y, Z?
Actually, there is within the PB framework provisions for that. So basically, PB in literature, PB has been presented as a 6-level process in Makueni, starting from village, cluster, sub-ward, ward, sub-county, and county. My belief is that PB honestly works between the village and the ward level, because it's meant to redistribute ward development finances and resources. Yeah? So by the time a list is agreed upon at the ward level, you have technical officers from the Ministry of Finance and Socio-Economic Planning in Makueni interacting with the different wards and telling them, you know what, you may want to consider not having this dispensary here because your neighboring ward is going to get a dispensary here. Why don't you have it in a central area? Or perhaps have a technical officer suggesting, last year you guys got something invested in the area. Why don't you, because of limited resources, why don't you consider your neighboring village? Yeah. So there is that level of feedback, and there's also another level of feedback now from the presentation of the budget proposal at the county assembly, where now the MCAs come to their wards and get to mobilize Interesting enough, their process has been accused of mobilizing citizens who are not involved in the initial participatory process. So they mobilize for their own people, then ask for feedback. Is this indeed what you asked for? Did you ask for a dispensary here? Did you ask for a road here? Then they can get to make their own assessments, but they only have a 10% leeway of making adjustments to the budget. So to some degree, there is a bit of feedback where the government comes and tells you, you know what, this is what we are considering. Yeah.
Okay. So with that, if there's another question, we will close. Thank you very much. I guess it is for you to give us a sense of equity
since it's only me, I can be wired, eh?
Say?
Since it's only me, I can be wired.
Yeah, you can be wired, so you can roam around. I guess it's really to give us, much more close from the grassroots, what's going on and where you think this whole conversation around equity and resources and budgets and citizens participation. I think basically it's kind of to take into account all the conversations we've had and try and figure out, which of these applies to you in terms of your challenges, your opportunities, and where you see things going forward.
Thank you.
Okay.
Allow me to sit. I think that was the initial plan. When I was asked to come and speak, initially I asked, do I need to make a PowerPoint? So when I was seeing PowerPoint presentations, I was getting very excited. But then I was told specifically that it's just going to be a conversation, like a 5 to 10 minute conversation. You don't need to make any PowerPoint. So my name is Tom Boyer. I'm a medical doctor by training. It's interesting the conversation we're having because I think I've been to most of these other areas that data was being collected and represented here. In my first year, after my first year of med school, I volunteered at the New Nyanza Provincial General Hospital. So then I have an idea of how that facility runs and operates. The third and fourth year of med school, I'm in the pioneer group that started off the Kenyatta University School of Medicine. So the third and fourth year, we were training at Thika District Hospital. And then the fifth and sixth year, we relocated to Kiambu District Hospital. Putting in mind that Kenyatta University is still in the process of coming up with their referral hospital, which is really big. I took part in the mobilization in terms of capacity building for the Concept University Teaching and Referral Hospital. As the Students' Body President, I was the Students' Body President for KUSA, Kenyatta University Students Association, in my 6th year of medical school. So the university management and the people doing the hospital mobilization. So it fits that I represent the student's body as well as the medical school in that. And so I have a little bit of information here and there about how good the health facilities run, how the system may have been before and how it is right now. With that in mind, my first posting internship was actually at Kiambu District Hospital. So when you're talking about Kiambu County, that information as well. And then when I was absorbed into the ministry now, post-training, my first center was Mbagathi District Hospital, which was previously called Infectious Diseases Hospital, IDH. And then from Mbagathi, I was reposted to Pumwani Maternity Hospital. So there again, access to healthcare, the regions covering that place, that information is with me. And then I was recently now posted to Kibera South Health Center, now where I'm the medical officer in charge, so I head that facility. Interesting to note that all these facilities that I had been to previously, before being at Kibera South Health Center, most of these facilities were level 5 and level 6. And these are facilities that patients come. You know, they don't hassle for patients. Because the patients are referred from these dispensaries. So someone, for instance, traveling from Muranga gets an accident along Thika Road, the other end. The first stop is Thika District Hospital. I think most recently you know about the passing on of our governor. So when you look at that system, and it's quite unfortunate that the governor succumbed and died in this whole process. But from a medical angle, when I look at it, I think it is a wake-up call to us as a country on preparedness as well. And also how sometimes there's a group of people who can access medical care based on their insurance, then there are those who cannot. And it's tricky in the sense that even if I have medical insurance and something happens to me at a place where I can no longer use my medical insurance for healthcare, then I have to use the public facility. And so that's why this is really important. Because take an example of the governor. When he had the accident, he was rushed to a government facility. At that point, luckily, the nurses were away from their strike. They had come back to the facility. We also had doctors on the ground. And then when he succumbed, he was transported to Lee Funeral Home in a Kiambu District Hospital. Unfortunately, at that level, when he was now passed. But at the experience of us in the health facility, this is why when we had the in the country, and doctors were saying, we have the facilities sometimes, we don't have the equipment to use in these facilities. It was a bit of a challenge, and some Kenyans were not understanding, especially the middle class, when they were, they came into the discussion. Because in the middle class, you do not understand that when someone is unwell, and they go to a facility like Kibera South Health Center, which has a very good history, because Kibera South Health Center was initially being run by MSF, which is a non-governmental organization. Basically what MSF did is they built this facility in the year 2013, and in the year 2016 they were handing over this facility now to the county government. From then on, the handing over lasted about a year, which ended up in June of this year. When they were handing over to the county government, there was need to partner, because what the MSF did, and this is about access to healthcare. In places like in the slum areas, people have to discuss. You have a discussion with your family. When a prescription is written, you're told go and buy this medicine. It's for malaria. You have to think, will I buy the food for the house, or I'll spend these 50 shillings on the medicine? And so what NGOs have done in the slum area is to provide most of these things for free, which is both good and of course also has a negative effect that people then in the slums do not try to work hard to access resources. But a lot of these services were being offered for free. So the challenge then we had, and especially now that we are taking over from a system that the people around were used to, free medicine. When they come into the compound, it is free consultation. They see the clinicians for free. They see the doctors for free. There's even a maternity center there where the deliveries are free, just like it is in government hospital right now. And even the medicine is free. But Kibera South is unique because of that MSF support. Like the medication being given there right now is going to end by December. There'll be no more free medicine. Now, picture that as a facility, and then let's picture Kiambu District Hospital, for example, whereas there's this co-pay. You pay a little bit, you start access some services. Only maternity is free, but of course, maternity has a limit normally. Like when it starts getting into surgery, then you start paying a bit. When you look at Nairobi, for instance, Pumwani, delivery is free when it is normal, like those where you come in, you have the maximum of 3 days in the facility, you deliver a healthy baby, you walk out, no charges. When it gets into surgery, it starts getting complicated, then you may now start being asked to pay for beds and things like that. Because as a whole, you know, when free things are being offered, unfortunately, and this is even when you talk about the 70-30 rule, when we think about offering things for free, we don't think about sustainability. So where we are at Kibera South right now is where we are now thinking of sustainability now. Because these people will access the doctors and the clinicians for free. But then now when it comes to the medicine, which MSF used to offer to them for free, they'll now need to be buying that. And whatever is not available in the hospital pharmacy, then they have to look for a way to access it. And KEMSA supplies the medicine and all that. Whatever is supplied by the government is always subsidized, but then when they go out there, especially for non-communicable diseases, which we are getting a lot of right now, hypertension, diabetes, and then now there's the bigger cluster of people living with HIV, and they need support for that. And then we have really expensive diseases, like when someone has diabetes and you're on insulin, for example, that's a very expensive disease. And luckily for people living in such an area, then there's support, you know, the insulin and things like that are really subsidized. Now, when we talk about equity, coming from a place where most of the patients who come to the facility already have a mindset that I may be asked to pay something, that's okay. But when now they come to a facility where they used to pay nothing, and then you start asking them, now I've treated you, but here's a prescription for the medicine, you may need to go and buy this, then that starts to bring a problem. And since June this year up to now, we've been doing mobilization of the community and, you know, informing them that as much as a few things have changed, most of the services still offered are actually free. And the only parts that you may need to pay is for a service that is not in the facility. Maybe at this point I need to say that I don't speak for the county. I'm not responsible for the actions of the county. I'm only responsible for what is within my level. But overall, when I look at healthcare before devolution and healthcare after devolution, when we look at it really, really closely, you'd realize that devolution has been such a good thing to health system in the country because of two things. One, infrastructure-wise. There are places where to get a dispensary, you know, it would be so hard. But then post-devolution, we've had, you know, also for political goodwill, these governors want to be re-elected. So they throw a dispensary here, upgrade a hospital there, you know, for their own re-election, which is a good thing. Unfortunately, like someone raised it earlier, sometimes we don't think about the personnel. So whereas the infrastructure is being improved, the software, the soft skills are not being improved. The second thing that devolution has really helped us with, and it has spread it now to even areas like Kibera South, in a facility like that, you'd never find a medical doctor. But right now, we have medical doctors there. So you see the effects of devolution. There are places where you'd go and you think that the person in a white coat is actually a doctor attending to you, when in real sense, that is maybe a clinical officer. The highest, you know, that you'd find is a clinical officer. And the community guys will be, daktari, daktari, and his word is final, you see. So devolution has really helped us. And then there's something that Marakwet County, for instance, is doing, which most of these other counties in the far-flung areas are also doing, which has really helped us with equity in terms of distribution of services. Doctors traditionally wanted to be near Nairobi or near big towns, Kisumu, Mombasa. In these areas, when you're a specialist, apart from working in the government, you can also set up your clinic and run it. And so there was no motivation for a doctor to want to stay in Marakwet or for a doctor to want to work in Marsabit. But then some county governments, interestingly, in the pay packs for doctors, which is not announced, is that they offer you like a return ticket for two in a month, like to and fro from the cities. So they lure people to go and work there with the promise that at least every month you have a return ticket to the capital city. And so that alone is something that is interesting people who have families, because at times, you know, you've already established your family here, and someone is sending you to Wajir, and you think about it, you say, let me go into private practice, okay, or I may as well just quit government. But now doctors have the incentives, and some counties pay allowances for people to work in those areas under the category of hardship allowances. So that is something that is really a plus. But when you look at now services, in terms of the cost of services provided, we have facilities that already people are aware when you go, like when you go to Kenyatta National Hospital, you know that they'll start you off with a small fee at the beginning, you know, you open your file or you know, something like that, and then you get in. Now there are facilities, especially in areas where, I would call them like in slum areas or in areas where NGOs have gotten a hold and are really assisting, especially the NGOs. They make our people not think about some of these services are things to pay for. And as a result, when they go to co-paying systems, then it becomes a disaster for the people they leave behind. So that begs on the question of sustainability. When they come and do these things, they set up facilities, which is very good, but when they leave, then how sustainable are those developments that they leave behind? Yeah.
Okay, so we have a few questions to put because I've already. So any quick questions? I think he's touched on basically most of the things we've been talking about this morning.
So my question is about affordability versus quality, as compared to quality of access to service.
Yeah.
Now, I know in many situations, especially in low-income areas, people will prefer to cut the medical chain. Instead of going to a doctor and pay for consultation, why don't I just walk straight to a pharmacy? And I'm sure it also happens maybe around in this room. Why not just go to a pharmacy and explain, I have red eyes, and this is how I look, this may be how I feel, and the pharmacist just prescribes to you. Or ask a neighbor, when you are suffering this disease, what did you take? So you prescribe for yourself. So, and part of it is an affordability question, that if I go to all these places, I am going to be charged. I'm likely not to find a doctor, or I'm going to be charged a lot of money, and at the end of the day, I will still have to pay, for this.
Yeah.
And the compromise of that on the quality of medical care, because really, it's really low quality. I mean, I don't want to say it's low quality, but it's bad quality of medical care when I have just to go and get a diagnosis straight from a pharmacist without any proper process of diagnosis of what exactly I'm suffering. How do you balance that at the very local level, as you said, in Kibera, just to ensure that people are actually being given a service that first they can afford, but at the same time is of good quality?
Thank you. Can I take that?
Yeah.
Unfortunately, healthcare on its own is really expensive. Take an example of those of you who visited mainstream big private hospitals like Nairobi Hospital. Or Aga Khan Hospital, or Mata. It starts off with consultation. And at consultation, you drop 1,000 bob or 1,500. By the time you're done with consultation, when you have a test, you may drop another 5,000, 4,000. After that, imaging. If it's, God forbid, if it's a CT scan, you're dropping another 24,000 flat, or 16,000 for something, or 30,000 for MRI. That's how expensive healthcare is. And some of these costs eventually have been, inflated from a layman's perspective. Don't quote me for this. But then also insurance companies do not make the consumer feel the pinch directly, So when these costs are being inflated, or as they go high, and they're expensive for real, like it's really expensive to buy an MRI machine. It's totally expensive to maintain it because it needs specialized care, some of which comes from outside the country. So like I said, I was part of the team that was doing the capacity building tours for the Kenyatta University Teaching and Referral Hospital. And one of the places we visited was South Africa. Some of our equipment is going to come from Germany. So when you look at all that, whoever is coming to maintain this MRI machine has to come from South Africa, to fly into the country and train a few people to run it. when you look at that and then you quantify it in terms of the expense, that's why at the tail end, when I'm doing an MRI for you, it is going to be 16,000, it's going to be 24,000, depending on the hospital. So healthcare in itself is really expensive. And so that's where the government really has to come in and make it easy. Now, before our generation of doctors, there used to be doctors that did not rely on CT scans. I mean, they'll just listen to your complaints and keenly and say, that's malaria. And give you medicine and hope you don't come back, you get well. But right now, medicine is evidence-based. That's why we have a number of lab tests. Outside the country, there's litigation now. You know, like I do not just send you to go and do 3 tests in a private hospital or 10 tests and then pick from that. I have to, based on your complaints, I have to like pick out, like maybe I'll send you for these 2 because there's something I'm thinking. By the time you're done with your history, I'm in a condition already. So when I send you for 1 or 2 tests, I'm more specific than where now we have commercialized healthcare. Now, for government facilities where we are not looking at it in terms of making money for the hospital or for the health center, it is now expensive for the government, you know, to pay doctors, to pay the lab techs and all these people. But it still boils down to first contact with the doctor. It is expensive in the long end because someone will go to the pharmacy, meet a farm tech. The farm tech is not trained to diagnose. So when he thinks you have a red eye, he may not know it's because of an injury. Just throw in an antibiotic and a steroid. And then it's not improving, so you go to another one and the third one. By the time you think, hey, this is serious, now you come to the hospital and the general practitioner says, has seen you already. That's a cost to the government, not to you. And the general practitioner says, now you need to see an eye specialist. Now I'll send you to an ophthalmologist. So you see now at the tail end of that course, it becomes more expensive because you went for a shortcut. Whereas had you come to see a general practitioner, they would diagnose and then throw in the right medication. So when you run away from these costs, you still go all the way around and come back and pay. Yeah.
Okay, any other questions? My question to you is, from a public financing perspective, in terms of public support and allocation of resources to counties, who then allocate them to the various sector needs. How much goes into understanding these equity questions? For instance, how much level of public funding can we expect to meet some of these equity expectations? And how many times can we try, approximate it until we more or less kind of figure out? Like for instance, if a woman is coming into Pumwani, how do you make sure that whatever other costs that are in there, it's still, because some of the procedures could be actually beyond their control, but then can they pay? As you say, it is three days of use of the facility, it's a normal delivery. If there's any operations, procedures that are intrusive, then that's a different cost structure. But again, part of it is, it then beats the purpose of opening the door, and then once somebody comes in, then you start to say, well, there are exceptions to free. Yeah.
Thank you so much. Maybe to answer your question, I'll take you to the most recent development. How many of you heard about NHIF saying they're limiting outpatients to 4 visits? I've been in those NHIF discussions. Sometimes it becomes like really expensive. I mean, for political expediency, we quickly say, let's make these things free, let's get the votes. But then when it comes to the actual implementation, you realize these things cost money. And we probably needed to have thought about sustainability. And that's why, even when it comes to free deliveries, and right now NHIF wants to roll out something else in the free maternity side, where it's more of like an insurance scheme, where the money is given directly to the, right now, let me just give you the history. Right now, money from NHIF is given straight to the counties. Then the counties dispersed to the hospitals based on the expenditures in the maternity side. What NHIF is coming up with is the possibility of money being paid directly to the hospitals where these patients are attended to. What that means is, for instance, if a facility like Pumwani, Mbagathi, or a facility like in Wote District Hospital, the old name, if in Wote they've seen 150 patients this year, or they've seen 1,000 patients for this quarter, then they are paid for the expenses of their 1,000 patients directly as Wote, so that they're able to continue running with the program. But what we've had in the past, and that is why free maternity has been such a challenge to most places. You remember when Governor Kidero had said they wanted to discontinue, they were writing memos, and there was something in the media that they wanted to discontinue because they were not receiving the funding for free maternity care. Now, when the money comes to the counties, at times the allocation again is a problem. So some facilities will receive more than others and are not dependent on how many patients they were attending to. So that is why it becomes generally expensive. But in terms of equitable distribution, I think NHIF is probably on the right track to think about paying for the services directly, where the number of patients who come are paid for and the hospital is compensated. Then they're able to buy usables, because for one patient that you deliver, you're using gloves, there's so much that you're consuming. And so they're able to make it sustainable like that.
Okay.
Okay, thank you, Dr. I'm interested because in the morning you were talking about the importance of partners in the counties.
Yeah.
And here you have brought a case whereby when MSF was relocating from Kibera, there was a challenge on the handover. And I think one of the questions was being asked, what do we do with the human resource for health? For example, the workers who are employed by MSF, were they all of them absorbed by the counties? And what is the implication of that? Because when you talk of the public-private partnership, I think that's, you see now the MSF invested in a facility. They ran it for some time. And now there was supposed to be a seamless handover to the government so that the services can continue. But then now it brings the challenge of the absorption and sustainability of those services. And I think that now brings the issue when we were talking in the morning, there was some counties may be having more partners who are partnering with them. What would be the implication if those partners were to relocate? We know we have a challenge in the funding with the different partners who close some of these programs abruptly because of the political implication or other challenges that may come about. And that has a lot of shifts maybe affecting the health sector and also the issues of accessibility to the health. I don't know from your experience how that has been sorted out in MSF.
Thank you. Thank you so much for that question. And I hope I did not vilify the partners, because the partners are the best thing that has happened to healthcare in this country. Like the best, the very best. Look at malaria, the Wellcome Trust, people are in those systems. Look at hypertension, look at HIV. We would not be having our population affording ARVs, were it not for these partners coming on board. So the partners are the best thing that has happened to our health system. In fact, without them, I think our health system would be failing. When you look at how MSF, when they were relocating, they really invested a lot of time and energy. This relocation started in 2016 because they had to prepare the population. And interestingly, like I said, I've worked in other areas where it's a level 5, a level 6, where you don't go out there and ask patients to come to your facility. In a place where MSF was based in Kibera, word goes round. Those people live in one big village where when something happens, by word of mouth, neighbor to neighbor, neighbor to neighbor, they can even discourage patients from coming to a facility. So when MSF was leaving, they did a lot of mobilization. They used community health workers to try and sensitize them and let them know that we'll be relocating, but the services will still be ongoing for these people to continue. What they also did is most of the staff that were working there were actually absorbed by the next, because they handed over to AMREF, which AMREF was now not going to be able to take care of all the services that MSF was focusing on. When they handed over, one of the things that had to happen is that those employees, some of them had to take a pay cut You know, it normally starts like that. When a big partner is leaving, everyone who's left behind has to either look for greener pastures or you take a pay cut, things like that. So that happened. But then systems did not stop. Nothing was interrupted. I mean, they really invested in the handing over. But now you see sensitization of the community is now based on when MSF was leaving, now they started thinking, we'll now be paying for everything. But whereas all the other services will be free, the only things they may need to chip into is things like medication when drugs are not available. So most of the partners, when they are coming into the country, the government is very keen to ask them, how sustainable is this project? What's your exit plan? And they always have to come up with an exit plan. So, but no matter how robust an exit plan is, it normally has that 2%, 5% that will really, drag it down. But every partner has an exit plan, and partners in the healthcare are the best thing that has happened to us.
Thank you for your presentation and what you've spoken to. I feel like your presentation has been so refreshing because it feels like it's really happening. And I just want to appreciate the fact that your stories are very, I resonate with them because this is a little segment we thought, let's take it to the real world, what happens. And I remember wondering last week, because last week I was at KNH for maternal care, and they were like, where's your NHIF card? I'm like, isn't this free? Like, why do I need an NHIF? Now I see why I needed an NHIF, because I wanted to ask, and the nurses were like, we have too many patients for your craziness. So I am so glad that there's some, like, I see the point, and it's a question of sustainability. You're saying you're giving free maternal care, but there's all this cost that they have to incur. Where's the money for these things, Like, I understand that it's a very political decision. We're going to get more votes if we say this. So I really appreciate the fact that you have shared your experience. I just wanted to get your insight on the hiring policy in the county that you work in terms of, from practice, would you say that counties now, like we saw, most counties are hiring more doctors, dentists? Is it an efficient way of using money? Would you say that we need that much in the counties? Like, I just want to get the insights on your experience on how you evaluate counties spending on health workers. What is your take on it?
Thank you so much. Let me answer it in two parts. The first part is the NHIF thing. I think much as they are taking the cards now, they introduced something else because they realized there was that gap. Now they're registering people on an SMS model, so that even if you don't have a card, then you're registered using the phone, a facility phone, so that you're in the system. So they're capturing everyone in the system, and that's how they'll be able to, kind of like refund the facilities directly. So it's a good thing. It has hitches. The panel beat it everywhere they go, and they find a corner, they straighten it. So that's working. When it comes to hiring of professionals, because healthcare is quite specialized, I would say that the counties put priority where they think they should. There are those counties that never had surgeons, so you'd find far-flung off areas, they put, like, they really need to have a neurosurgeon in their payroll. So they decide to have a neurosurgeon and offer him 2 flights, return flights to Nairobi as a motivation, or 4 return flights, tickets. And that is just it, as devolution unravels, because this is really new to the country and to the governors, every step of the way, there are hitches that are being straightened out. A county like Nairobi has everyone here. When the doctors were going on strike, those who went, for fear of you thinking I was on strike, even if I was, or I was not, when the doctors were going on strike, they were saying almost 50% of the doctors in the whole country are in cities and big towns, and Nairobi takes the bigger chunk. And out of those who are not in Nairobi, almost the other 50% of total number of doctors in private practice are either in Nairobi or its environs. So that will tell you that every time doctors are being posted, for whatever reason, from the ministry, from everywhere, there's a lot of influence. People trying to say, post me into Nairobi, post me here. The remainder will say, post me to Kisumu, post me to Mombasa. And then now they realized that Kiambu is just as close to Nairobi. So whereas everyone is struggling to get into Nairobi, I can only struggle to go to Kiambu, or I struggle to go to Machakos, or I struggle to go to Kajiado, because it's still within the same vicinity. So a few of those things have really influenced staffing, because people want to be close to amenities. And it's difficult to blame them because of the obvious things. You know, maybe you've started a family, you're now a specialist, you've been training here at the University of Nairobi, your children are going to Mangu or another school around here. You don't want to relocate with them to Marsabit. So those are some of the challenges that doctors have. Now, posting of doctors in the past would also have been like a disciplinary measure. Yeah, so if you're medicine, and that would be it. So those are some of the things that the union has really tried to streamline, and you don't want to know how happy doctors are about the county governments, because once you're in Nairobi, even if they are to relocate you, they'll send you somewhere within. Marakwet. Not that you're taken from Marakwet to Mombasa as punishment, you know. So a lot has happened. Posting still ideally is influenced and is supposed to be influenced by a need. Like I said earlier, if a facility doesn't have a theater, why do you send a surgeon? If a facility doesn't have a need for dispensing specialized medicine, why would you need a pharmacist to go and sit at the periphery when they could help from a main facility? Yeah.
Okay. So I guess that's the end of it. Yeah. Yeah.
Thank you.
Good. Thank you very much.
Thank you.
Thanks.
Thanks a lot, Dr. Tariq. We totally appreciate it. And now I see, as Mokera has just said, the total wisdom of having this last panel. It's just tied everything together. Mine is to say two things. First is, just as a wrap-up of this conversation for today, is that we try to get these different perspectives. And you've noticed we've gone from very highly technical data stuff that Caleb presented, you know, to softer, to human resource issues, to more softer public participation issues, to the conversations about what's going on at the Wellcome Trust, to what we've just closed on, what's going in the ground. What is it we are saying? The choice of picking a sector focus in this Equity Week, healthcare being one of them, tomorrow we'll be looking at a bit about infrastructure, is to show that sometimes we get lost in this big picture of, you know, either there's a problem everywhere, or everything is fine. You know, so there are certain nuances that even in places where you think things are very good, but there are also pockets of effectiveness in areas you think things are very bad. So I think that's one. But the second thing I want to say as we come to a close is also an appreciation, which I come to appreciate even from this conversation, that most of our conversations around policy, around things like healthcare, are technical in nature. But I think what this forum tells you is that most of these matters are also political. If anything, I think they are more political than they are technical. You know, from the questions around how posting is done, to how budget allocations are done, to whether there is consideration of equity issues when monies are being allocated, to how dispensaries are being distributed. All these are political questions. And I think it's important for us as practitioners in different spaces to actually approach this conversation from that dual perspective, that it is at the same time technical and at the same time political, and not necessarily one or the other. I think that will help us to get into spaces where we can penetrate a bit more, because I doubt a governor of a county would care about the analysis and the background analytics that we have done. They just want to know, so tell me, how do I get dispensary in that corner? No, how do I make sure health services improve in that corner? So with those two remarks, I want to say thank you very much, guys, for honoring our invitation. The rest of the week, KenyaEquityWeek.org. It up. right? And we have activities tomorrow. We are in Strathmore. We are going to focus a lot on infrastructure, roads, and water. On Wednesday, we are at the Kenya National Theatre for a day of softer conversations around, normal people doing normal things around fighting inequality. And then in the afternoon, we have an essay competition that we'll be giving awards to some high school students who have done quite some amazing write-ups. On Thursday, we have in the morning, DI, Henry has just stepped out. There will be a launch of another platform that is looking at something more specific, that's trying to map socioeconomic data on budget allocation data, Spotlight. So please do check in on that on Thursday morning. And then in the afternoon, we have a community event where we'll have quite a number of organizations working in our community areas to fight inequality in their own areas. And that will be on Thursday afternoon. On Friday, we are in Elgeyo Marakwet, where we are bringing about 8 counties together. Just basically share their reflections and their perspectives on what they do to fight inequality. So you can tell it's already a full agenda. Happy if you can participate in all of them, but extremely happy if you can participate in one more. Thank you very much.
Kama Grace hapo.
Grace, I think bado yuko hapa.